Welcome. In this explainer, we are digging into a really clinical update on post-exposure prophylaxis for chickenpox. All the material we're covering is based on the fantastic work of Dr. Mohammed Mohammed. We're going to walk through a major change in practice, one that's going to directly impact how you manage some of your most vulnerable patients after an exposure. So let's get right into it.
So let's start with the classic scenario. An immunosuppressed patient walks in, tells you they've been exposed to chickenpox. What do? This is a common, often pretty urgent situation we all face. And here's the thing. As of late 2024, the answer you might have learned is now completely wrong. New UK guidelines have fundamentally changed the game, making our old protocols obsolete.
Okay, here's how we're going to break this down. First, a quick look at the risks. Then, the 3 essential criteria for deciding who gets treatment. After that, we'll hit the big news, the practice-changing update. Then get into the nitty-gritty of the new regimen. And finally, we'll wrap up with the key takeaways you need to know. Right, so first things first, let's just quickly set the stage. Why is post-exposure prophylaxis, or PEP, so incredibly important for certain patients? Well, it's all about looking beyond what we typically think of as chickenpox. You know, for most healthy kids, chickenpox is a mild, self-limiting thing. But, and this is the whole point, for our immunosuppressed patients, for neonates, or for pregnant women, the varicella-zoster virus is a whole different beast. It can cause severe, systemic, and sometimes life-threatening disease. It's not a benign illness for them, and that's why this whole protocol exists.
So how do we figure out who actually needs this intervention? Thankfully, there's a really clear, systematic, 3-step framework we can use. Let's walk through it.
Before you even think about writing a prescription, you've got to be able to tick these 3 boxes. 1. Was the exposure actually significant? 2. Is the patient in a high-risk group? And 3. What's their real immune status? Are they actually susceptible? Let's break each one of these down. Okay, criterion number 1, confirming a significant exposure. This means they had real contact with an infected person while that person was infectious. It's also worth pointing out a little nuance here. If someone was exposed to, say, very limited shingles lesions that were completely covered up, that might not be enough to warrant PEP. But this brings up a key question. What is the infectious period? And this is such a vital clinical point. You see, for a healthy person, the infectious window is pretty short and defined. But for our immunosuppressed patients, it's a different story. They can keep shedding the virus for a much longer time, basically until every single one of their lesions has fully crusted over. That longer period really expands the potential for exposure. Criterion number 2 is pretty straightforward. Is your patient in a high-risk group? We're talking about anyone who's immunosuppressed, so your patient's on long-term steroids, methotrexate, biologics, you name it. And of course, this critically includes neonates and pregnant women, who both face some really unique and serious risks from this virus. All right, step 3. We have to confirm the patient is actually susceptible. The best way to do this is with an urgent blood test for their VZV IgG antibodies. Now, you want to get this done fast, but here's a key point. Waiting for the results should not delay starting prophylaxis if you're getting close to that day 14 cutoff. Now check this out, because the numbers here matter. We use different goalposts to define who's at risk. For an immunocompetent patient, we say a level below 100 means they're not immune. But for an immunosuppressed patient, we're more cautious. We use a higher threshold, less than 150. And that just reflects the reality that their immune response might not be as strong, so we need a higher level of antibodies to feel comfortable that they're truly protected. And now we get to the absolute heart of this explainer. This is the practice-changing update. If you've managed this problem before, what you're about to hear is a fundamental shift in UK clinical practice.
For as long as most of us have been practicing medicine, the answer to this problem was always the same. VZIG, varicella-zoster immunoglobulin. It was the standard of care, the go-to treatment.
Well, not anymore. As of September 2024, that long-standing protocol has been completely replaced. This right here is the single most important slide. VZIG is no longer available in the UK for this purpose. The new first-line treatment for all at-risk groups is now a simple course of oral antivirals. This isn't a small change, this is a complete replacement of the old standard of care. Okay, so we've established the what. Now let's get into the how. What are the practical details? How do we actually prescribe this new antiviral regimen? Now this is really interesting and maybe a little counterintuitive. We do not start treatment right away. You actually wait. The optimal window to begin the antiviral course is between day 7 and day 14 after the exposure happened. So here are the details you need for the prescription. The drug is either oral acyclovir or valacyclovir. You'll tell the patient to start it sometime between day 7 and day 14 after they were first exposed. The course itself is for 7 days. And what's really helpful is that if a patient comes to you a bit late, you still have right up until day 14 to get them started. Just a quick but really important side note here. We mentioned pregnant women are a key at-risk group, and they are, but their specific management has some extra layers of complexity. So that detailed guidance is covered in its own topic and is a bit beyond what we're covering in this general update. Okay, let's pull all of that together. We're going to consolidate this into the essential must-know points that you can take away and use in your practice tomorrow. All right, here it is, your 30-second summary. 1. Always use that 3 criteria framework: exposure, risk group, immune status. 2. Remember that higher IgG threshold of 150 for your immunosuppressed patients. 3. And this is the big one: VZIG is out, oral antivirals are in. 4. You're prescribing a 7-day course of acyclovir or valacyclovir. And 5, you're starting it in that specific 7 to 14-day window after exposure. And this big change really leaves us with a forward-thinking question. I mean, we've gone from a specialized, hard-to-get infusion to a simple, accessible oral prescription. So should this change our whole approach? Instead of just reacting to exposures, should we now be proactively screening all of our at-risk patients for VZV immunity before they're ever exposed? It's definitely something to think about.